Bone infection diseases. Published by WordPress.com. Orthopedic infections, acute and chronic osteomyelitis. Acute hematogenous osteomyelitis. Definition. Acute suppurative inflammation of bone and bone marrow, predominantly seen in children but can occur in adults with lowered resistance, diseases, drugs. Organisms. Gram-positive, Staph aureus, 90%, Strept, Pneumoniae, Staph, Epidermidis, Group B hemolytic Strept. Neonates. Gram-negative, Haemophilus influenzae, E. coli, Pseudomonas, IV drug abusers, puncture wounds, Salmonella, common seen in sickle cell disease. Opportunistic pathogens, fungal and actinomyces in immunocompromised patients. Sites. Children, metaphysis, especially around the knee, supplied by end arteries, loop, liable to trauma and actively growing. Adults, spine, discitis and osteomyelitis. Pathological stages. 1. Inflammation. Acute vascular congestion leading to intense pain. 2. Suppuration. Pus formation causing subperiosteal abscess and thrombosis of nutrient vessels. 3. Necrosis. Bone death, sequestrum, at 7 days due to vascular compromise and infective thrombosis. And 4. New bone formation. Involucrum forms around sequestrum. Clinical features. History of septic focus. General. Fever, anorexia, headache, malaise, FAHM. Local. Redness, hotness, swelling, tenderness. Pain, localized. Limping or inability to bear weight. Lab studies. CBC. Leukocytosis greater than 12,000, PMNL greater than 50%. CRP. Rises within 2 hours, peaks at 48 hours, and normalizes within 1 week of successful treatment. ESR. Normal within the first 48 hours, rises rapidly and gradually declines with effective treatment. Blood cultures positive in 50% of cases during fever. ASOT raised in 50% of cases. Radiographic studies. X-rays. Normal in the first 10 to 14 days, showing soft tissue swelling initially followed by patchy rarefaction and sclerosis. MRI, best. Bone scan. Gallium, indium scans may show increased signal intensity. Management. Conservative. General. Analgesia, fluids, nutrition. Local. Splinting. Empiric broad-spectrum antibiotics followed by 4 to 6 weeks IV treatment. Operative. Indicated if failure of antibiotics or chronic infection. Techniques include pus evacuation, debridement, and drilling. IV antibiotics followed by wound closure and possible repeat surgeries. Complications. Metastatic infections, septic arthritis, chronic osteomyelitis, pathological fractures, and growth disturbances. Chronic osteomyelitis. Classification. Tierney, CT-based. 1. Type 1, medullary. 2. Type 2, superficial. 3. Type 3, localized. And 4. Type 4, diffuse. Clinical picture. History of acute OM or recurrent infections. Pain, swelling, sinus discharging pus. Investigations. Cultures from discharge. X-rays, showing sequestrum, involucrum, cloaca, and patchy sclerosis. MRI, sinograms for extent of involvement. Management. Conservative. Similar to acute OM, with longer-term antibiotics and symptomatic management. Surgical. Radical debridement, with techniques varying based on infection severity, e.g., segmental resection, vascularized grafts, Elizarov technique. Complications. Chronicity, reactivation, malignant transformation, and growth disturbances. Special types of chronic osteomyelitis. Chronic sclerosing osteomyelitis. Diaphyseal, tibia, jaw. Diffuse sclerosis with encroachment on medulla, no sequestrum or pus. Treated with cortical drilling. Chronic multifocal recurrent osteomyelitis. Multiple, eccentric, metaphyseal lytic lesions. Symptomatic treatment with no effective antibiotic therapy. Subacute osteomyelitis, Brodie's abscess. Mild due to less virulent organisms and greater patient resistance. Predominantly affects children and young adolescents.